Medicare Advantage sales rules are changing, and that matters more than it may seem at first glance. Because the way a plan is described to you can shape the healthcare you end up with for the entire year. Starting June 1, 2026, new federal rules will adjust how Medicare Advantage and Part D plans can be marketed. These changes will impact advertising for the 2027 coverage year. So if you or someone you care about is comparing Medicare plans, this is exactly the kind of update where a few simple words, like best, cheapest, or top rated, can sound reassuring, but hide a much more complicated reality underneath. And understanding what to look for could help you avoid choosing a plan that looks great on the surface, but creates problems later. Now here's the core of what's happening. The Centers for Medicare and Medicaid Services, or CMS, finalized new rules for Medicare Advantage and Part D plans for the 2027 contract year. The rule was published on April 6, 2026, takes effect June 1st, and applies to coverage beginning January 1, 2027. In simple terms, the rules are being updated right before the next big Medicare enrollment marketing season. CMS says the goal is to improve quality, increase access to care, and simplify parts of the enrollment process. And on the surface, that makes sense. Medicare is complicated. You're dealing with Original Medicare, Medicare Advantage, Medigap, Part D drug plans, premiums, deductibles, copays, networks, prior authorization rules, and a long list of extra benefits. So when regulators talk about reducing paperwork and simplifying enrollment, it's easy to understand why that sounds positive. But not everyone agrees with how these changes will play out. Some consumer advocates are concerned that simplifying certain rules may actually make marketing less clear at a time when clarity is more important than ever. One concern is that plans may have more freedom to use broad marketing terms like best, top, or cheapest. Another concern is that some broker disclosure requirements could be reduced. And perhaps most importantly, there are concerns that beneficiaries may not always be clearly informed about free, unbiased counseling services like SHIP, the State Health Insurance Assistance Programs. SHIP counselors don't sell plans. They don't earn commissions. They simply help people compare options and understand what works best for their situation. And for many seniors, that kind of neutral guidance is one of the few protections against confusing or high-pressure marketing. Now, this doesn't mean Medicare Advantage is bad. It also doesn't mean all brokers are misleading. And it definitely doesn't mean these plans don't help people. In fact, many people are very satisfied with Medicare Advantage. Some save money. Some appreciate bundled benefits like dental, vision, hearing, fitness programs, transportation, and even over-the-counter allowances. For someone on a fixed income, a $0 premium plan can feel like real relief. But here's the key point: $0 premium does not mean $0 cost. You may still face copays, coinsurance, prescription costs, provider restrictions, prior authorization requirements, and out-of-pocket limits that vary widely between plans. So when you hear terms like cheapest, the real question becomes, cheapest for whom? Cheapest for someone who rarely sees a doctor? Cheapest for someone with no ongoing prescriptions? Or cheapest for someone whose healthcare needs look completely different from yours? That's the heart of the issue. Medicare is personal, but marketing is general. Advertising is designed to simplify complexity. It takes a huge system and turns it into something easy to understand in a few seconds. But healthcare decisions don't always fit into a few seconds. A plan that works well for your neighbor may not work well for you, even if you live in the same area. Take dental coverage, for example. An ad might highlight it as a benefit. But the real details matter. Does it only cover cleanings? Does it include crowns or dentures? Is there an annual limit? Which dentists are actually in network? And are you willing to switch providers if your current dentist isn't included? The same applies to doctors and hospitals. The real question isn't just, is my doctor covered? It's, is my doctor in network for this exact plan, in this exact year? And what about your specialists, your preferred hospital, or the clinic you rely on? One of the most common surprises people face is discovering too late that their trusted providers aren't included. Prescription drugs are another major area where confusion happens. A medication might be covered, but that doesn't guarantee it will be affordable. You still need to understand which tier it falls under, what the copay is, whether prior authorization is required, whether step therapy applies, and which pharmacy offers the best price. These details matter more than most advertisements ever explain. And with the new rule changes, some of that responsibility may shift even more toward the consumer. That's why it becomes important to ask direct questions when dealing with brokers or sales representatives. For example, do you represent all Medicare Advantage plans in my area, or only some? And are you compensated differently depending on which plan I choose? These questions may feel uncomfortable, but they are completely fair. This is your healthcare decision. And while many brokers are helpful and honest, incentives and plan relationships can vary. Transparency is what helps you understand the full picture. Another change in the new rule involves call recordings. CMS is shortening the required retention period for marketing call recordings from 10 years to 6 years. Supporters say this reduces administrative burden. Critics worry it could make it harder to investigate disputes in the future. Once again, it comes down to balancing efficiency with accountability. There are also updates related to Medicare Star ratings, which are used to measure plan performance and influence payment structures. CMS is removing some measures that are considered repetitive or overly focused on administrative processes. Supporters say this improves the system. Critics worry it could reduce accountability and affect long-term costs. For most beneficiaries, these policy debates may feel distant, but they still influence how plans are designed, marketed, and funded. So what should you actually do with all of this? First, don't treat ads as final answers. Treat them as starting points. Second, be cautious with big marketing words like best, top, or cheapest. Always ask, based on what? Third, focus on your own needs first. Make a list of your doctors, medications, preferred hospitals, and expected healthcare needs, then compare plans against that list. Fourth, review your annual notice of change if you're already enrolled. Plans change every year, and so can your costs and coverage. And finally, when possible, use independent resources like Medicare's official plan finder or unbiased counseling services such as SHIP. The key point is this: Medicare Advantage isn't something to rush. Because while marketing is designed to make decisions feel simple, your health needs are not. A good plan isn't the one that sounds best in an ad. It's the one that actually works for your doctors, your prescriptions, your budget, and your long-term care needs.